Latest in urologic healthcare. This time, we're in the Big Easy, and all of you will have access to the latest in your specialties and finally be able to engage and connect with your colleagues in person. AUA TV starts right now. Hello, and welcome to New Orleans, everyone. My name is Dina Baer, and I'll be your host for AUA TV. Stay tuned, as this year we'll be covering all of the latest in the field of urologic care, highlighting organizations that are making big waves in urologic care, and also speaking to experts presenting on site. First, let's dive into the economics of healthcare. Dr. John McConnell and Dr. Jennifer Miles-Thomas are joining me now, and we're talking about the economics of healthcare, more especially physician compensation, and really how these models are changing. Can you talk about that?
Yeah, there's been pretty radical change in the last 10, 15 years. It's been driven by several forces. One is more and more physicians are being employed by health systems and other entities. And the practices, even that are independent, are getting larger and larger. And they've had to move towards systems that are much more formulaic in the way that physicians are compensated. And there's a good part of that in terms of simplicity, transparency, but it's been very challenging for many physicians to live in this new world.
So do you have advice for physicians on how to navigate that to really maximize their potential for compensation?
Yes, I do. I think the first important aspect is to understand how you are compensated. And a lot of physicians, including myself, when we first start out, we really don't understand the models or why we are compensated a certain way. So I think it's important for each physician to understand how they're compensated and then to make sure that aligns with actually what the patient needs.
And how can they take that and then be able to maximize the time with patients versus the time that they're taking to really focus on this stuff, which is also critically important?
Yeah, I think everything is a balance. And so honestly, in our practice, and probably yours too, you really have to do a lot of prep work beforehand. You really need to walk in with a baseline understanding of what the patient needs during that visit, and also come back with a plan for that patient so that you can be most effective during the time that you have.
And you know, one of the important points we covered in our course yesterday, especially for younger urologists looking at their first opportunity or so, is you're very focused on the compensation. You need to understand what the practice is like, what the culture is like. Is it dedicated to patient care? Are there resources available in terms of the staff support, equipment, et cetera, that would allow you to be maximally efficient? Because virtually all these models have some component of productivity, and the more efficient you are, the better you're going to be.
Right, I feel like what I'm hearing is if you get good at this, figuring out the compensation, then you're going to be able to benefit your patients in a whole new way. Talk about how patients are actually doing better once physicians have a handle on all of this.
Yes, I think that physicians can craft their schedule to be maximally effective, but maximally effective for the patient. So right now there are many different avenues, including telemedicine. And some visits actually don't need to be in person. So that definitely benefits those patients who maybe have difficulties coming into the office, or they're very busy professionals who still need that health care. And it's just the ability to do it on the go has significantly changed.
What's the most important piece of advice that you would give a new physician now?
You go first.
Ask questions.
Yeah.
Yes.
I agree totally. Yeah, and again, I think the focus that many of the young people have in mind is I have debts. I need to know what the monetary component of my new arrangement is, and that's very important. But some of these other factors, I can tell you from my personal experience, things derail often for non-financial reasons. The culture of the practice, resources. You find out after you get there that you have to go to outreach clinics and things that you were not aware of. So ask questions.
So what's the best place to turn for those resources?
I would say find a mentor, because you definitely can ask those questions, and you don't have to be in that situation where you may be asking the practice, someone that you're not as familiar with. You want to ask those questions in a safe space so you can really dig deep and find the correct answers.
Yeah, we're hoping over time, we just launched last year this new AUA curriculum and then expanded on it at this year's meeting. But hopefully the AUA itself will have additional resources. But I could not agree with Jennifer more. The best thing you can do is talk to more senior people from a variety of experiences and have somebody walk you through. The legal advice is important, but it's probably not the most important.
Well, already you two have acted as mentors just by doing this interview. So Dr. McConnell, Dr. Miles Thomas, thank you so much.
Thank you.
Thank you.
Dr. Stephen Campbell is here now, and we're talking about updated AUA guidelines for localized renal mass. Thank you so much for talking with us and taking the time. First, let's discuss how the need came about to know that there needed to be updated guidelines.
Well, there's just been, through the years, a fair amount of heterogeneity in the way that patients with localized kidney cancer are evaluated, counseled, and managed. So the main objective of the guidelines is to provide very granular recommendations that the everyday urologist can use in their daily practice to help them to know what would really be the best course of action for this patient population as they're evaluating and managing them.
So let's talk about what some of those changes are.
With this guidelines update, which was 2021-22, we've updated the literature through 2021. One of the major things we've done is we've merged together a previous guideline into the main guideline. This is the guideline for follow-up after intervention. And so rather than being a separate guideline that's now merged into the main guidelines, it's also updated. We also have updated a number of other recommendations, such as our recommendations for genetic counseling. For the first time, we have recommendations regarding adjuvant therapy. One of our main recommendations relates to the issue of partial versus radical nephrectomy, and the AUA guidelines are really the only one that provides a really granular description of the criteria that should be met for radical nephrectomy versus partial nephrectomy. And we're really hoping that that will facilitate appropriate management of patients such that the ones who really need the radical nephrectomy get it, and at the same time radical nephrectomy is not overutilized. Also in these guidelines, we've sort of updated our recommendations about renal mass biopsy, which should be mostly just used in a utility-based approach whenever it might influence management. And also we've updated our recommendations about active surveillance and thermal ablation.
So when you think about the diagnosis, the treatment, the follow-up for patients, this is going to make a big difference.
Well, we're hoping this will be very helpful, again, for the urologists in their daily practice to give them recommendations and guideposts. You know, at the end of the day, you don't always have to do what the guidelines say. If the patient's very old or frail, it might change what you're going to do, but it gives you sort of a guidepost to help you to decide how to manage these patients.
I imagine for physicians that is comforting as well to know there are specific things I know I should be doing to make sure I'm giving my patients the best care as a standard.
Well, and of course that's sort of the philosophy behind all the guidelines, and I think the guidelines, the AUA has done a wonderful job with this, and I think it really is very helpful for urologists in their daily practice, but also for our residents and our fellows as they're learning the field.
Where can doctors find these guidelines so that they make sure they know what they are?
Yeah, they're certainly on the internet. If you Google AUA guidelines, renal mass, you'll almost certainly end up in the right place. But also, with all the guidelines, we provide an executive summary in the Journal of Urology, which is condensing the 80-page guidelines with all the rationale and all the ins and outs of the literature and condensing it into about a 5 or 6 page guidelines. Now, since we merged the two together, it's actually 2 executive summaries in the Journal of Urology that came out this past year.
Okay, good to know. Dr. Campbell, thank you so much. This is such important information.
Okay, thank you.
Dr. Greg Tajan joins me now, and we're talking about genetic testing for early onset kidney disease. Thank you for being here.
Pleasure. Thank
So
you.
before we talk about advancements and your research, I want to back up a little bit to discuss traditionally How was testing and treatment done, and how will that maybe change based on your research?
Sure. So the paradigm for testing in kidney stone disease has really revolved around 24-hour urine testing. It's a way we look at the urine chemistries to understand risk factors for why stones developed, and then also to identify ways that we can target specific medications to reduce the risk and therefore prevent recurrence.
And it's important because it's truly very painful for people.
It is. So it's an episodic disease that can occur repeatedly throughout the lifespan. Over the last 20 years, it's happening more and more in young individuals. The age of onset has become much younger. The gender gap has disappeared. But it's also a disorder of mineral metabolism, higher risk of hypertension, higher risk of fracture, cardiovascular disease. So it's much more than painful episodic events.
So your research is twofold. Explain.
So we really seek to understand what's driving this change in the epidemiology of the disease, and then as we unravel these causal mechanisms, really identify new opportunities for diagnostic test development and therapeutic development.
So when you look ahead to the future, what would your goal be?
So I think as technology has evolved, we have a real opportunity to do targeted genetic testing of individuals with early onset kidney stone disease who have a higher risk of having a monogenic condition. There are now commonly available panels that can be done in the clinic and sent out that can identify many different causes of monogenic disease, including primary hyperoxaluria, cystinuria, distal RTA. And now we have the opportunity to have targeted treatments, particularly with RNAi for primary hyperoxaluria. And that's, I think, one area that's currently available. Where I think we've reached the boundaries of knowledge for clinical care is in understanding idiopathic kidney stone disease and what new diagnostic testing and therapeutics look like there.
And there is a connection potentially to the gut, which you are looking at, that I think not a lot of people have even thought about.
Indeed. So we've discovered that antibiotics are associated with an increased risk of incident kidney stone disease. And then in understanding the sequencing of the gut microbiome and all the associated metabolites, there's definitely perturbations in individuals, particularly younger individuals with calcium oxalate stones. And this reduced diversity of the microbiome is reflected in a lot of different ways. There's decreased capacity to produce butyrate, which protects the gut, and if you're missing that, you absorb a lot of those minerals, including oxalate, that produce kidney stones. So as we really work to understand this, I think we can identify ways that we can test the gut or the urine in new ways to reveal new causal mechanisms and targets, but also develop new treatments, such as restoring or replacing the gut microbiome.
It's such an understudied area.
It is.
And so I feel like this opens the door for many other things potentially to impact the genetic testing for early onset kidney disease, but maybe other things as well.
I think that's right. And I think that's especially true when you conceptualize stones as a disorder of mineral metabolism, much more akin to other systemic disorders rather than just a simple episodic painful event.
Well, Dr. Tejnan, thank you so much for sharing your research with us.
Thank you.
While we're here, we're going to be taking a deep dive into universities and healthcare organizations making a difference in the field of urologic care. First, we head to Texas.
We only treat hypospadias and related birth defects at the Hypospadias Specialty Center. Dr. Bush and I specialize in this because it's so important that the operation be done right the first time. When surgery doesn't go well, the risk for complications with subsequent operations doubles, and then it goes up from there.
Hypospadias can be broken into three major components. Number one, the urinary channel is in the wrong spot. Number two, there's short skin on the undersurface. And number three, there's various degrees of curvature. So to repair it, we have to fix these one at a time.
Hypospadias doesn't just impact the patient, but also his parents and others in his relationships into the future. Hypospadias really does matter.
Next, let's take a look at some of the work being done at the St. John's Cancer Institute Urology and Urologic Oncology Center of Excellence.
Our small startup program in urologic oncology at Providence St. John's Cancer Institute is small but mighty. We offer a state-of-the-art, academic level, cutting-edge urologic cancer program and urologic cancer services to the city of Santa Monica and West Los Angeles. The heart and soul of our program really is our urologic oncology and robotics fellowship for fully trained urologists to spend more time learning about minimally invasive surgery with an emphasis on robotics and urologic cancer.
We have a whole spectrum of agents available for treatment of advanced urological tumors, including immune drugs that activate patients' own immune system to fight cancer, hormonal agents, particularly in prostate cancer, and also chemotherapeutics.
We're offering the latest current cutting-edge treatments offered at the best centers around the world.
The Christ Hospital Health Network has an exciting multidisciplinary collaboration among its urology, urogynecology, and colorectal departments. Its main location in Cincinnati, Ohio, features the Pelvic Floor Center, which is a dedicated space that offers advanced resources for the treatment of pelvic floor disorders.
Christ Hospital is located in Cincinnati, Ohio. We're very excited about our multidisciplinary approach to treating patients with pelvic floor disorders that occurs between urology, gynecology, urogynecology, and colorectal surgery, as well as having this pelvic floor center in which all of us can evaluate and treat patients. And it's a lot more comfortable for patients because it's a one-stop shop for them.
The multidisciplinary collaboration here is pretty remarkable. We've got some outstanding physicians with an incredible wealth of experience, breadth and depth of experience to work together collaboratively to lead to the best outcome.
Here at the Christ Hospital, we're lucky to offer a lot of up-to-date, newest technology to patients. In surgery, we have the Da Vinci robotics for various other cancers, but it can also be used for certain disorders of the pelvic floor, and urogynecology certainly is very involved with that as well, including colorectal surgery.
The Sabah Al-Ahmad Urology Center in Kuwait is a comprehensive specialized urology center providing urologic care excellence and training the next generation of urologists in Kuwait's urology residency program.
Sabah Al-Ahmad Urology Center was established in 2013 by order of His Highness the late Emir of Kuwait, Sheikh Sabah Al-Ahmad Al-Jaber Al-Sabah. What makes the center unique is that it is the only center in Kuwait and the region dedicated completely for urological care. So we have units in uro-oncology, pediatric urology, infertility, andrology, endourology, reconstructive urology, and others. Our goal and our mission is to help patients, support doctors to help patients, and improve urological care through research. We look to recruit qualified urologists to be involved in local and international research projects, to train our urologists in the residency program to become better urologists, fully qualified and independent, and to try and innovate and bring more technology that comes back for the benefit of the patient.
Dr. Francesco Montorsi is here now talking about excellence in urologic care. This is a rather broad term, so tell me a little bit about your talk and specifically what you mean by excellence in urology.
What I mean by excellence in urology is to give our patients the best possible care, which is not only surgery, it is not only the results coming out from an operation, but is also being empathic with patients, making them as happy as possible, not only themselves, but also the families. And there is not only one ingredient to reach this target. There are many things involved. And in my talk, I discuss the value of mentors, because we can choose our mentors during our career. I'm saying we cannot choose our parents, but we can choose our mentors. And that is important, because a mentor is somebody who is helping you to make explode your qualities, to become a better person in your career. So that is one thing. And then also being very humble. Go visit the others, because you want to learn new things. And it is important to recognize that there are others who are better than yourself, at least at the beginning of your career, and you want to learn from them how to improve. The concept of the learning curve, for example, is important for those who know their results. I'm talking specifically for surgery. If you know your results, you know what you are doing bad and what you are doing good. If you know what you are doing bad, you can improve. You want to change things. You want to change your surgical techniques, for example. And so it is a never-ending journey to be as good as possible.
So you have some marching orders. What do you think the biggest challenge is right now to being able to achieve that?
I think that the biggest challenge is to be humble enough to recognize that, at least at the beginning, we are not perfect and we can do something better. And even more important, once you think that you have reached a top level, be humble again and say, I can do better than this. So in a way, it's good to be happy of what one is doing, but I think it is important also to be on the other side and tell ourselves, yes, I have done something good, but most probably I can be even better than this. So find good questions, which is the first step. It is not easy, but then having the will to find the best answers.
When you talk about surgery, it's something that is easily practiced, a skill that is gained. When you talk about empathy, it's not quite that simple, is it?
That is true. Empathy does not come by itself. But indeed, again, let me restate one more time that humility, being humble, is important, because one also, if you are clearly the number one in one field, feeling himself or herself being like an emperor is not good, So we are here to help patients and do all we can to improve their lives. So there are always things that deserve to be learned.
You talk about this idea of helping. If someone doesn't have a mentor, what are other resources that they can look to?
Well, I think that it is difficult not to have a mentor today, because a mentor is not necessarily somebody you see every day or you work with. You have examples all over. Reading books, reading newspapers. We are exposed to life 24 hours a day, and it is important to see what is going on outside, in the outside world, and then asking ourselves, what am I doing to do as good as I can? So there are no excuses.
That's a great way to end it. There are no excuses. Be excellent. Looking forward to your talk. Thank you so much, Dr. Montorsi.
Thank you very much.
Today we got the chance to connect with multiple startup organizations looking to enter the urology space, and they're showcasing their products or services in front of thousands of urology professionals. Let's see what they have to show.
The mission of our company is to offer an improved alternative to the 100 million patients worldwide that rely upon the 80-year-old design for the Foley catheter, which is too often associated with infections, blockage, pain, distress for patients, and billions in potentially avoidable healthcare costs.
For us to be able to exhibit here is massive, because it gives us a chance to demonstrate the Flume catheter to people and to show how the balloon is enveloping the tip And this is so different and contrast to the Foley, where the tip is prominent and damages the mucosa.
Our device is like an electrocardiogram for the penis. Right now, nothing like this exists in the world. In this age of healthcare wearables, smartwatches, MyZones around the heart, this is the first smart underwearable. With this device, we can measure 4 parameters. We can count the nocturnal erections that are indicative of vascular health. We can measure the impact of medications, recreational drugs, alcohol, supplements, exercise on one's erectile fitness. We also can measure 3 other parameters: the duration of erection. So if a man suffers premature ejaculation, we actually can measure, well, how long is that man's erection? And what is the impact of medications on that? Are the medications really improving it? We also can measure the firmness of the penis and the strength of the ejaculatory contractions, which are also reflective of vascular health. And now we can actually evaluate how well things are working. To be here at AUA is great. This is a revolutionary product. I believe this product will transform the practice of urology.
So the mission of urologylocums.com is to provide urologists with a lot of different opportunities in which they can work to increase their economic earning potential, as well as be able to deliver much needed urologic skills to communities around the country. What this means to us is that it's a great opportunity for us to meet a lot of the urologists that we work with here in person. Also for us to be able to get to know a lot of other hospital systems that are exhibiting here as well. But also to let the community know that we're here. As a newer company, but in the last 2 years we haven't had the opportunity to get together and meet, so we're really excited to get out and meet people in person. So it's going to be a great time.
Let's go ahead and continue our tour of organizations leading in urologic care. This time we head to the nation's capital, where the urology program at MedStar Georgetown University Hospital is embarking on a transformational phase of growth and exciting opportunities. Buoyed by the forthcoming completion of its new hospital construction, MedStar Georgetown University Hospital will have more space to offer expanded patient services, surgeries, training, and research.
MedStar Georgetown University Hospital is located in the heart of Washington, D.C. The urology program has always been considered one of the best programs in the country.
Urology at MedStar Georgetown is growing rapidly, and we have so many all-star urologists. I'm one of the early adopters of Retsia-sparing prostatectomy, first described by Antonio Galfano and Aldo Borciardi. Retsia-sparing prostatectomy is a newer form of robotic prostatectomy.
There are 8 major steps. The first is port placement.
The next step is peritoneal incision and the vas deferens and seminal vesicle dissection. Step 2B is then the posterior dissection. Step 3 is the lateral pedicles and nerve sparing. Step 4 is the bladder neck dissection. Step 5 is the anterior apical and urethral dissection. Step 6 is anastomosis. Step 7 is peritoneal closure. And step 8, when needed, is lymph node dissection.
Retsia-sparing is just a start. We want to be a step ahead of the curve on anything that looks like it could benefit our patients.
The Department of Urology at Henry Ford Health is proudly celebrating its centennial year. The department has an incredible legacy of innovation, marking many firsts, including being the first in the United States to perform a robotic prostatectomy and the first in the world to use a robotic-controlled ultrasound probe to remove a cancerous tumor from a kidney. As one of the nation's largest and most advanced centers for common and rare urological needs, the Vattikuti Urology Institute offers leading urology services. Let's take a closer look.
So our department is known for a legacy of innovation, particularly in robotic surgery. In fact, the revolution of robotics started here. So this year we celebrate the 100-year anniversary of our department. And we've been truly blessed with visionary leaders. We're very excited to continue this legacy of innovation now for our patients. So some of the exciting things we're offering now: single port robotic surgery, fully robotic HIFU treatment. In fact, we are the first institution in Michigan and one of the few in the country to offer both single port prostatectomy and fully robotic HIFU treatments. I mean, innovation is in our DNA. That's what we're about. We're truly one team. We're engaged together with a common purpose.
Well, that's it for us today, but don't worry, we'll be back tomorrow with more exclusive content from the 2022 AUA annual meeting. We'll see you tomorrow.